My name is Frans Cronje. I'm a South African medical doctor. Thank you for the opportunity to talk to you about spirituality and healthcare, a patient-centered approach. The purpose of this presentation is to afford you with some basic principles, perhaps some guidelines and thoughts that may assist you if you would like to include spirituality as part of your healthcare practice. At present, you may feel intimidated, or you may not know where to start in speaking to a patient about spiritual matters. Perhaps there are concerns about offending people or being misunderstood. With some basic principles and guidelines, it really is rare to offend people if done in a frank, earnest, sincere, and open way. And it has many potential benefits. There are many things to consider, of course. Healthcare brings its own challenges, and the additional dimension of spirituality can really add an additional layer of complexity to that equation. But it also adds a great additional resource, and that is the perspective that we should hold. So I hope that I'll be able to give you some new ways to look at this, ways that perhaps will facilitate the role of bridging the gap between the conventional scientific healthcare world and the patient's deep emotional and spiritual orientations. We're really looking at resources, many of which may not be realized unless we are willing to probe, albeit in a gentle, thoughtful, wise and sensitive way, what religious or spiritual resources may be available to assist our patient. The key is patient-centeredness. Patient-centeredness frees us from the former parochial or authoritative approaches that were quite common in healthcare. What it has done is it has given us an environment in which there is joint decision-making and responsibility. The benefit is that it now releases us from the need to be insistent about our perspectives or feel that we need to impose our expertise on unwilling subjects. One of the lessons I've certainly learned the hard way is that we tend to move from a state of ignorance when we acquire knowledge about a particular topic or skill. We then develop an approach or a recipe or some sort of system in which we develop a confidence, certainly, but often a certain amount of arrogance. After some failures or some adverse events or perhaps some negative responses from patients, we start modifying this approach and we realize that it has to be set in a relationship. And that's when wisdom comes. And that's the area, or the point at least, that we should achieve as quickly as possible. Now, I'm going to approach this primarily from a Judeo-Christian perspective, simply because that is what I'm most familiar with, and also because it represents the majority of our population. But it is equally plausible that there would be different approaches, although the principles are likely to be the same. In this, I would like to say that most healthcare providers either struggle with being, let's call it, closet believers, in the sense that they have a very active, or at least formal, spiritual or religious lifestyle that is practiced over weekends, but then on Monday morning the professional scientific veneer returns with a very pleasant but very reserved interaction with patients. Many of us are frustrated with the schism between our worlds and wonder how it may be possible to move closer without getting into trouble. Some of us may even feel compelled, out of compassion or because we really believe it would be helpful, to offer some sort of spiritual intervention. When we do so, we may often wonder whether we have crossed some line or confused our professional relationships. That is to say, even more complicated when we consider being reimbursed for the time we spend. This is an additional layer of complexity that I cannot cover here. But if I were to answer the question whether or not we should address spiritual matters in our patients, my response is an unambiguous Yes. But what I would like to add is 4 important perspectives. Firstly, spirituality is actually a part of human physiology. Why I say that is because in practice we tend to look at spirituality in the form of religion. In other words, as a series of brands to which people choose to be loyal. We all obviously believe our brand is the best, and therefore we're usually somewhat naturally judgmental about the other brands others have chosen. This is true even within the Christian faith spectrum. In fact, quite dramatically so. But it becomes even more pronounced or perhaps awkward when we encounter other expressions of faith. Note that my reason for saying this is not to propose that you compromise your beliefs or to somehow encourage you towards some type of Unitarianism. Not at all. What I'm saying is that, like you, I also have strong spiritual beliefs, but to be of service to our patients, we need to start from a different perspective that is able to engage with them wherever they are and whatever they believe. So what I've chosen to do in this talk is to therefore emphasize the physiological nature of spirituality, for which religion then becomes the specific formalized expression. It is normal for human beings to be spiritual, and therefore within this function of normality, we need to assess their needs. In this approach, we can then encourage dialogue without becoming intimidated or causing concerns about being disloyal to our particular expression of spirituality, conviction, or denomination. Secondly, disease is primarily a prompt for relational restoration. Let me say that again. Disease should really be seen primarily as a relational crisis that is in need of restoration. And this, of course, is at many levels. Between the individual and God, between the individual and themselves as their health becomes affected, and things like body image, the cause of illness may all play into that relationship. Their relationship with others, both in terms of the possible precipitation of the disease or perhaps the alienation that may follow as a result of the disease. All of these are very important considerations. And if we focus on disease as a relational issue rather than only a health one, we develop a healthier approach in general. No matter what the circumstances, cause, or consequences of an illness may ultimately be, all disease is a prompt for relational restoration. The greatest contribution any person can make towards another person when their health is in jeopardy is to serve as a facilitator for relational restoration. Disease is a relational issue, first and foremost. Thirdly, if we consider the central tenet of our professions, primum non nocere, which is first do no harm, then we are actually compelled to assess the spiritual needs of our patients. I'm differentiating assessing and addressing. Last year during a wound care conference, I presented a talk on healing the heart, and this was one of the summarized slides, and that is that spiritual needs can be assessed and addressed without prolonged training or prohibitive investments of time. They can be met without provoking offense, projecting judgment, precipitating guilt, promoting alienation, perpetuating superstition, or propagating magical thinking or producing escapism. These are all concerns that have been raised by people who are critical about including spiritual aspects in healthcare. We believe that the spiritual dimension offers meaning and comfort, greater partnering and compliance, restoration of relationships, and relief of suffering. And scientific evidence actually bears this out. Therefore, we cannot allow our own ignorance, prejudice, or fear to prevent us from addressing the spiritual needs and realities of our patients. for to do so would be to deny their reality and human dignity. It limits access to essential resources in the healing process and therefore violates the very precepts of our profession. In other words, it is ethical healthcare practice to assess a patient's spiritual needs. Where the rub comes in is here, because lastly, if we do decide to address the spiritual needs of our patient, we must only do so with their consent and with a necessary sensitivity to the health institution's policies and, of course, the patient's religious preferences. So, the way I like to ask for permission would sound something like this. Many patients appreciate it if their doctor prays with them for their health. Many patients have reported relief and comfort. As such, I would like to offer you that opportunity, if it would be meaningful to you. But please, feel free to let me know if it would make you uncomfortable, or if I need to be sensitive about the way I pray for you in any way. My intention is only to support and to bless you, so please feel free to express exactly how you feel. I have found that this approach almost never offends anyone. There may be the odd surprise simply because the matter is raised. I have had refusals, but without a breach in relationship, and I have had many responses of acceptance with gratitude. This approach is simple and provides a dignified opportunity for people to either accept or refuse the spiritual intervention in question. So, how do we now take it further as a healthcare provider? Well, firstly, we're all busy. A lot is going on, and it's hard to keep track of our own fields of expertise, let alone bringing in this whole new dimension. What I've found helpful to me is realizing that there are three natural prompts in most healthcare encounters. And this is really common for pretty much all forms of healthcare. There is an initial background consideration, there is an assessment stage, and ultimately there is some type of intervention. I found that these three checkpoints often provide an opportunity to at least consider introducing a discussion on spirituality in a particular case. It's always best if the question can be introduced naturally, simply as a matter of routine, and thereby be done in complete safety. One of the instruments that have been very helpful in approaching spirituality as a generic assessment is firstly to ask the question, does your religious or spiritual belief provide you with comfort, or is it potentially a source of stress at the moment? Secondly, do you have spiritual beliefs that may influence your medical decisions? Fourthly, are you a member of a religious or spiritual community, and is it supportive of you? And finally, are there any other spiritual needs that you would like someone to address? This neutral but very comprehensive approach affords a patient many opportunities to discuss potential conflicts, concerns, and the need for spiritual support. If done sensitively and earnestly, it may often encourage a patient to open up. Now, for practitioners that simply don't have the time, at least consider one question. Do you have any spiritual needs or concerns related to your health? It's open-ended, and the patient may either embrace or avoid engaging. During the course of a patient clinical encounter, there may often be an opportunity for a patient to mention something about their faith or confidence in God. Affirming this then offers an immediate anchor point and a certain amount of permission to go there. Obviously, the most important priorities are to deal with the medical issues, but in approaching a spiritual discussion, the areas that are probably the most productive would be the potential barriers to relationships with God and, very importantly, relationships with others. Many people have a very strong relationship with God, but they have very troubled relationships with themselves and other people. Although I cannot go into great detail here, I would like to remind you of a Bible verse that is extremely helpful for those that make use of the New Testament. In the book of James, there is reference to what has become a very common ritual in various forms of Christianity, and that is to have the elders pray and anoint an individual with oil. What is often forgotten or omitted is the second part, and the second part of the same verse says, in order for this restoration to occur, sins need to be confessed one to another, and prayer should be communal so that healing occurs as a natural consequence of restored relationship. This is actually a very important and in fact a very original model for healing in a spiritual setting. In the Old Testament, or the Tanakh, in Genesis 20, there is a very poignant vignette between Abraham and Abimelech, in which Abraham prays for Abimelech's fertility, which is then restored, and subsequently Abraham's infertility is restored when Sarah conceives. So again, it creates that dynamic of confessing, restoring relationship, together with prayer, leading to healing. Even the well-known book of Job documents that the Lord turned the captivity of Job when he prayed for his friends. And this is so necessary for discussion when it comes to spiritual matters. Now, there are some do's, don'ts, and dangers that one should consider. One needs to be aware that religion can conflict with care, introduce judgmentalism, provoke alienation, produce interpersonal strain, result in religious debates and disagreement, perhaps conflict in terms of religious striving or practices that may conflict with a person's health interests. It may cause social neglect if people become unduly focused on religion to the exclusion of all else. It may lead to additional levels of guilt and, of course, negative religious coping, where a person may feel abandoned or persecuted as part of their religious understanding of illness. Some dangers of addressing spirituality is that without the necessary preparation or consent, a patient can be confused or offended. The patient's family might be offended. If we are disrespectful, that can cause tremendous breach in relationship. A patient may suddenly be concerned that their life is at risk, such as that the priest is being called. Or it may result in the patient asking the healthcare provider questions that they're not prepared to answer or be unwilling to discuss. Nevertheless, the ability of religion to serve as a help in supporting a patient's ability to cope, strengthening the patient-doctor relationship even if there are differences of faith, promoting compliance, encouraging community support, actually changing the course of illness, and adding to the fulfillment of the healthcare provider are tremendous benefits. Therefore, the dangers can be avoided through patient-centeredness, taking care of medical priorities first, going towards general discussion before getting into the more contentious issues, using the simple spiritual history, requesting consent for any interventions, asking about sensitivities, offering prayer or interventions in a way that are consistent with the individual's faith and not compromising of your own, and always being respectful. To assist in this journey, there's some resources I'd like to encourage you to consider. David Levy is a neurosurgeon who's published a book called Grey Matter, in which he discusses his journey of introducing prayer as part of his clinical practice. He discusses some tricky situations of overcoming his own shyness to pray for people, initially for patients, eventually together with colleagues, and even collectively. He also discusses his frustrations when the outcomes were not good in spite of prior prayer. So it's a very good, friendly, colleague-to-colleague discussion of practical spirituality in health practice. On a more formal level, there's the book by Harold Koenig on spirituality in patient care, the why, how, when, and what. Also a book linking religion and health, giving some idea of the mechanisms involved. There are books on parish nursing and partnering between the healthcare community and communities of faith. Harold Koenig offers a workshop twice a year in which he discusses some of the research that can be done. There are a variety of questionnaires that can probe areas of spirituality, religion, and other faith-related parameters such as forgiveness that are readily available and validated for those interested in doing research. Mind-body medicine has come a long way, and there are increasingly well understood mechanisms that allow us to better understand how improved confidence, lowered stress, and other relational factors may improve health and may contribute towards people's well-being. Neuropeptides are becoming a very interesting area in the whole mind-body medicine continuum, and there are some resources to consider there. Our profession has a time-honored tradition. It has always valued relationship, and it has been sensitive of spirituality. The health profession grew from within spirituality, and it is time for us to restore that dimension in an appropriate, culturally sensitive, and ethical way. I hope that this presentation may have offered you some guidance, some perspectives that would be helpful in doing just that. Thank you.